Okay, well, welcome everyone to this Think Global. Want to welcome everyone in the room. Wonderful to see everybody, and I see that many of our students are here, which is fantastic, and also the online audience to today's Think Global, which of course we feel is really important to do, to get together to think about and discuss what is happening, and the title really speaks to what's going on. Lives on Pause, Implications of a U.S. Retreat from Global Health Fund. So as you've all undoubtedly been aware, following the news, there have been a number of developments, a number of very rapid changes, a number of pauses and holds, executive orders. It's very, very hard to keep up with all of what has been happening. And I'm sure all of you, and certainly all of us, the panelists, have been in a number of fora. And I think one of the things that's come across very clearly is that we all need to be together as a global health community and think about these things together and process what is happening and try and share our understanding. And I think if you really think about the sort of big picture, which is what we want to focus on, overseas development assistance, global health, where we are, where it's going, what these changes look like. It is very important, first of all, to acknowledge how very difficult a moment this is for everybody. Secondly, I think to say it is very important to shed light and not just heat on what is happening. We have tried to put together a panel today of people who really can help us shed light on these issues. Just before I introduce them, I do want to say a couple of ground rules. First of all, for the folks in the online audience, we will have questions after the initial round of questions that I'll ask each of our panelists. And if you would like to ask a question, please put that in the Q&A. We have not opened the chat function, but we do have the Q&A open. Secondly, we are recording this session, so it is on the record. And of course, that is important for many people, particularly for our international audience, working in an array of places, we understand. So just to know that it will be recorded and it will be archived. I also want to say that I know many people are likely to have specific questions about specific programs, specific grants, specific visa issues, and we are not going to be addressing that for the students in particular. We have a listening session tomorrow in which we will have expertise on the visas, on all of those aspects. So please hold those questions for then. And I hope that all of you can attend. We've tried to set that up. And that will be the education team, Joe Egger, and myself, along with our HR folks to help with those issues. This is not meant to be a political or a partisan forum. This is really a global health forum where we're trying to understand the implications of what is happening for our field and to have people with expertise across the policy, development, overseas assistance, and of course from our wonderful colleague Dorothy Dow, who is on the ground in Moshi, Tanzania, and is really able to shed light on what is happening very directly to U.S. overseas development grant recipients. So that's going to be the focus. I covered everything. So the format of today's event is going to be that I will ask specific questions of each of our panelists. We'll give them an opportunity to respond and shed their understanding and light on the challenges that the world and our field is facing. And then we'll open it up to you. So for the folks in the room, that's just a hand raise. And then, as I said, for the folks online, please come in on the Q&A function. And again, I just want to say before we begin, this is a very challenging time. It's been, for those of us who've worked in HIV/AIDS, as I have now for 30-odd years, the idea that we're facing treatment interruptions and interruptions of prevention of mother-to-child transmission, and not because, unlike the early years where we just didn't have the science and we didn't have the therapy, really a man-made decision and a health emergency that didn't need to happen. This is extremely deep. I just want to acknowledge that it's not easy to deal with what is happening. So with that, let me introduce our panelists, and you'll see very quickly as I introduce them why we've asked them to join us. Sarah Bermeo, to my right, is an associate professor of public policy and political science at the Sanford School here at Duke. She co-directs the Duke program on climate resilience and mobility. So she's worked on climate and migration. But very importantly, her research focuses on the intersection of international relations and development, including foreign aid, migration, and climate change. And so we really asked her to speak to her expertise, big picture about foreign assistance, overseas development. Gavin Yaney, who's certainly known to all of our students, is the Heimowitz Family Professor of the Practice of Global Health at DGHI. He directs our Policy Institute and also our Core for Advancing Policy Engagement. And he has been a commissioner on a series of Lancet commissions, including the ones on TB, on investing in health. So knows a lot about health investments. And so we're delighted to have him. And Gavin, it's going to be amazing to hear what you have to say.
No pressure. Amazing, apparently. Amazing.
Dorothy Dow, who's on the screen, is with us. She's an associate professor of pediatrics and global health at Duke, DGHI faculty, and she is our faculty lead, our champion in Moshi, Tanzania, which is where she's joining us from. She's worked in HIV prevention, which, by the way, HIV prevention through PEPFAR is one of the areas that is on pause. It has not been reopened. Also, orphans and vulnerable children, although the treatment programs have been opened. And her current research is focusing on the intersection of HIV adherence and mental health for adolescents. She's a pediatrician who does adolescent health, so that's also why we really wanted Dorothy. Thank you. We know it's late at night there. I don't know if Prof. Blandina is with us. She's the lead on the Tanzanian side for our Duke collaborations, but hopefully, well. And then finally, Gerard Radivosian. Gerard is the inaugural Hock Fellow at DGHI, and he very importantly served in the Biden administration, and he was the acting chief of staff at PEPFAR. He really knows a great deal about the PEPFAR program. And he's also been in the past on the Hill. He was the legislative director for Barbara Lee, Congresswoman from Brooklyn, who is retiring and who was the chair of the Congressional AIDS Caucus. So I've known Gerard for many years because we worked together on HIV legislation and funding PEPFAR reauthorizations in DC. And we're really delighted to have him with us. So I'm going to ask Gerard to kick us off because he is the closest to what is happening right now in DC. And Gerard, maybe you could just give us a brief update of where things stand, what we know about current global health funding, what's frozen, what isn't, and if you would, speculate a little bit on the future of PEPFAR, because it is obviously the largest commitment to a single disease in history by any government, and right now is responsible for the care of 21 million people.
Mm-hmm. Yes, thank you, Chris. Thanks for that kind introduction. You're always the best hype person for all of us, so really appreciate those kind words. Sorry that I'm not in the room with you all, but I'm feeling the energy through the screen. I know there's a lot of interest and passion around these issues. And so just to say thank you for caring and for being present, which is really important. The last 2 weeks have really felt like 2 years, really, for those of us who are trying to analyze the incoming. I have literally like 4 screens up, 3 phones, Signal chats, WhatsApp messages, people communicating privately, publicly. There's just a lot to digest and analyze. I thought I'd just take a step back to just describe how we got to the moment here, and it's only been 2 weeks. This all started on Inauguration Day on January 20th. Within a few hours of being sworn in, President Trump executed a lot of executive orders, and at the top of the list, and it's important to say that this was one of the early ones, there was an executive order on calling for a freeze of all new foreign aid programs and then calling for a 90-day review of foreign aid programs. Now, those of us who are policy wonks who analyze this stuff, we're not surprised by this executive order. We're, I think, surprised on the timing that he did it within a few hours. But if you were tracking Project 2025 and a lot of the rhetoric around the election, the Republicans were wanting to do this in terms of calling for a review, and it's perfectly reasonable to call for a review of foreign aid. It's a large component of the work that we do overseas, and that was one of the early executive orders. What transpired a few days after is what led to this cascading effects of panic, chaos, disruption, and lives hanging in the balance. And 4 days after the executive order, we saw an interpretation of that executive order by the State Department, and the newly sworn in Secretary of State, Secretary Marco Rubio, interpreted that 90-day review to be an actual stop order of all foreign aid programs with a very limited set of exceptions, including support for Israel, support for Egypt, and a few other very specific military financing aid efforts through the State Department. So that led to a real chilling effect across the foreign aid community, the global health community, across very different programs. You know, we have aid workers, thousands of aid workers across the world, implementing different programs. And what a stop order essentially means is that even if you are holding U.S. government money, if your organization, your agency has received money from the U.S. Treasury, you're not allowed to actually spend that money. And so that is what a stop order is. So lots of contractors of global health, a lot of big organizations that implement global health programming, and I know Dorothy's going to touch on this as well, had received this stop order. And remember, these organizations don't sit with large amounts of reserves. They don't sit with large endowments. They don't have any endowments, frankly. And so when you get a stop order, your program stops. That means you're not going to work the next day. That means your salary is not being paid. That means if you're operating the clinic, or if you need to turn the lights on in the clinic, you're not doing that, right? And so that is what began to unfold over the course of the last 10 days. And the stories, as you've seen and read and felt and heard, are becoming more and more omnipresent. A few days after that initial stop order cable that the secretary sent, emerged the process of a waiver request. Again, this is a very wonky Washington policy process that the State Department outlined that said that if there are good programs that need to get a waiver from this stop order, they announced a process for it. And the words that they used were life-saving. I'm looking at my notes because it's important to get these words right. Life-saving humanitarian assistance and essential medicines. And that was it. It was 5 words. And those 5 words with very little direction or very, very little directive allowed for a process of waivers to be requested by different programs. There's thousands of programs happening. So you can imagine the incoming at the State Department asking for waivers. Every program touches lives. So PEPFAR, which has been at the center of this, because as Chris said, it's the largest of the global health programs, the one that's currently kept 20 million people on HIV medication, saved over 20 million lives. A lot of advocacy around PEPFAR from the strong HIV advocacy community. Really, what happened was a waiver was eventually granted to PEPFAR, a very limited waiver that covered about 50% of its program. PEPFAR operates at about $4 billion a year. So just less than about 2 billion of it, which covers care and treatment, related services to HIV care and treatment, very limited prevention services, specifically for prevention of mother-to-child transmission was part of the waiver. But what's not included in the waiver, I think, is a bigger deal, and that includes programs for orphans and vulnerable children. As Chris said, about 17,000 of orphans and vulnerable children are served by a PEPFAR program each day. HIV prevention services in particular for key populations. Testing services, basic testing services are not part of the waiver, and there's a long list. Outside of PEPFAR, other global health programs did not get a waiver, including the President's Malaria Initiative, which I know Dorothy will touch on as well. So there's still a lot that while there is a limited waiver that's been received for HIV programming in certain areas, there's still a lot that's not covered by the waiver. So in the last 48 hours, what we're seeing now is some of these stop orders being rescinded, and now organizations are receiving these waivers to continue their programming, but there is a new challenge now, and that challenge is that the operational elements of the global health work has been frozen. A couple things to note there. First, the payment systems that are involved in unlocking funds for contractors to get paid, for organizations to be able to receive the resources to execute a program, that is still very much frozen. And so while a waiver, as you may have read in the news, has been granted, programs are still not able to execute because the payment system is still very much frozen. The other big assault here is what's happened to USAID. You've read the news stories about what happened in the Washington headquarters office, and I was just at the rally a couple days ago. Overnight, we got news that all USAID mission staff from around the world, thousands of people, were being called home by this weekend, which is extremely unprecedented. But USAID covers almost 2/3 of PEPFAR programming, and that means a lot of the USAID driven programming that's been authorized because of the waiver is not going to be able to be executed because a lot of staff were asked not to come to work. Their computers have been frozen, their access to data has been limited. And so there are key questions about, well, how is the vast majority of the PEPFAR program going to be implemented if USAID can't really operate? So that's a question that's top of mind for everybody. The only other thing I'd say is just beyond this current moment, Chris, as you asked, we're all focused on what this 90-day foreign aid review could look like, what programs are part of the waiver. But I think the big issue here is sort of what happens on the other side of it. A lot of programs like PEPFAR have an expiring authorization. There are key questions about what Congress might do to cut the overall foreign aid budget, and how these programs are going to operate when a vast majority of them that are operated by USAID have been severely curtailed. So lots of questions beyond the current moment that we're in about the future of foreign aid and the future of PEPFAR that we all as a community need to come together to begin to think about what that looks like. So let me stop there, Chris. Back to you.
Thank you very much, Gerard. That was, as always, tremendously insightful. It's a nice segue into asking Dorothy to speak to what it feels like and looks like and what is happening actually in one of the PEPFAR recipient countries, USAID recipient countries, also a PMI country, which is Tanzania. So Dorothy, please, live from Moshi, share with us what it feels like there.
Sure. Thanks, Chris, and thanks, everyone. It's really an honor to be on this prestigious panel. I mean, we faced this a little bit a year ago, or a little more than a year ago, as PEPFAR was up for renewal, but it seemed a little less urgent. I mean, as Gerard said, this all wasn't entirely unexpected to be re-reviewed, but it just all happened so incredibly quickly. And it's been really shocking and devastating, to say the least. But, progress has been, we've come so far with HIV treatment, and stopping PEPFAR really undermines and just derails all of that progress. As Gerard mentioned, there's 20 million people who receive antiretroviral therapy supported by PEPFAR. And thanks to PEPFAR, 5.5 million babies more now, whose mothers live with HIV, have been born HIV-free. I mean, we could go on and on about the good things that have come from this program, but after the executive order froze pretty much everything to do with foreign aid, and that included PEPFAR and delivery of any of the medications. Even if meds were on the shelf, pharmacists weren't allowed to actually give it to the person in front of them. And that just causes so much angst and moral dilemmas and so many questions. AMFAR, the Foundation for AIDS Research, quickly put out a memo that helped quantify the impact of the stop order, which it's shocking, and it's such a great memo. So I'm just going to refer to some of the data that is part of that. And so for every day of the stop work order, over 200,000 people, 220,000 people were estimated to not receive their life-saving medication. In Tanzania, we have about 1.5 million people who receive antiretroviral therapy through PEPFAR, and over 15,000 patients a day, including 600 children, showing up to get their meds from the pharmacy didn't get their meds if their clinic was even open. These are huge impacts, huge daily impacts. People don't have a lot of expendable income to show up to clinics, getting there, paying the transport. That all comes at a cost. And then to not get the care that you're expecting or the medication that you thought you were receiving, that's just devastating. It calls into question trust with the healthcare system and so many other things. HIV exposed babies didn't stop being born, and they weren't able to get the medicine that they need to keep them from getting HIV from their mothers. Those following up for care couldn't get their testing. They couldn't get their meds to prevent mother to child transmission of HIV. Estimated that 30 additional babies in Tanzania alone every day would become infected as a result of the stop order. So even, some damage has certainly been done. Thousands of clinic providers were told to stay home. This includes doctors, nurses, pharmacists, lab staff, community healthcare workers, thousands of community healthcare workers. These people aren't paid a lot. They really depend on that income, and the whole program depends on their work going out in the community and helping to bring HIV prevention and care to people. So this is massive impact, not just for health, but also really for the economy. When the limited waiver came out to allow some PEPFAR activities, as we heard, this is really based on treatment, such as dispensing that ARV medicine that was on the shelf. Now the pharmacist, if they're still allowed to come to work, can actually hand it on to the patient. This did offer some hope, but I think we have to really understand and emphasize that flipping the switch back on in these really complex systems and all of the caveats of understanding what's allowed, what's not allowed, this took time. So this didn't happen overnight after the waiver. Clinicians on the ground had to wait for directives. In some cases, as we heard, this is coming from USAID workers who have been laid off, unclear if they're even allowed to give the directives to turn the switch back on. So it's been very chaotic and confusing on the ground. This morning we had PMT-CT clinic at KCMC, the Kilimanjaro Christian Medical Center, and things were pretty much, operating again, thankfully. We had lots of patients and the pharmacists were back, but there are still lab folks who are not able to return to work. There's still a lot of community workers who aren't able to come in. So things are slowly operating, but it's certainly not business as usual. There's been chaos, pandemonium, people are scared, confused. It's pretty crazy right now. And just quickly, I'll give a personal example. As Chris mentioned, my work is really centered around adolescent HIV and mental health. And we were really excited. We've been doing clinical trials for 10 years. We've been kind of working towards potentially integrating mental health care into the HIV clinic. And through USAID reached out to us if we would be willing to help train up peer providers to deliver a condensed version of our intervention. And this was all pre-planned before the Christmas break. We were all set for training, and that training was to happen on January 27th. So I was on a bus to Morogoro when I opened my email and saw 10 minutes had passed, and we got the stop sign. So 2 hours in the bus ride, I got off the bus, I called the team, I turned around and I came back to Tanzania. So the ripples of this are huge. This is just one other piece, three regions in southern Tanzania where we were going to get to pilot and try to move mental health care into the clinic is stalled and possibly stopped. Everything canceled. So peer leaders who were on their way, some 12 to 14, 18 hours, Mwanza to Morogoro is a long way. They had to get to where they were going and spend the night and then go back. And there's no money, as Gerard said, all the money was frozen. So there's no reimbursement for these, sudden stops, really affecting everyone who was involved. So, it feels irresponsibly actioned from the US government. It honestly feels inhumane for people who are suffering all of a sudden. But we are still here. We are still doing our best to deliver great care to the patients who deserve our great care. But yeah, it's been tough. I'll stop there. I could go on. Thank you.
Yeah. So Sarah, maybe from the very specific, we'll broaden out and ask you to talk about the overall picture with foreign assistance. This is so much of what you do. And what do you think? Maybe you can help us think about what's missing, what's been mischaracterized about what is going on.
Well, I think the first two speakers, thank you, Chris. I think the first two speakers have done an excellent job characterizing what is going on. People like myself who work at it a little bit more from a distance have been working our phone networks for the last week or so. I've talked to, and I won't name any institutions because I promise not to, but I've talked to a lot of NGOs that are operating on the ground, trying to understand what this means for them. I've also talked to a lot of, I'm a political scientist by training, so talked to a lot of people within the political science field. And really what is, from a broader foreign aid perspective, though even outside of PEPFAR, as I've already mentioned, a huge portion of health aid is actually administered by USAID, whether it's PEPFAR aid or other types of health aid. So anything I'm going to say about USAID also applies specifically in the area of global health. But I want to make a couple of points. One is US foreign aid and the creation of USAID are authorized by the US Congress. It is unconstitutional, according to pretty much every constitutional law scholar out there, for the executive branch of the government to turn off that aid without going through Congress. If it's Republicans or Democrats, it is unconstitutional to do that. It is also extremely inefficient. I'm going to elaborate on each of these points a little bit, but it's very inefficient. You can't just turn foreign aid off and then back on again after 90 days. That's not how it works, especially if you, which we just found out about last night, pull all of the people back. People will die. I think our first two speakers have done a fantastic job of pointing that out in more detail than I can. It will make the US weaker in so many ways. But I will also say at the outset, and then I'll go back into each of these a little bit, there is absolutely room for reform in foreign aid. People like myself have been calling for reform in foreign aid for some time. It's just that the way it's being done right now is inefficient, counterproductive, and destructive. So this is not, everything was great at USAID, it should always stay the way it was, but there is nothing efficient or humane about the way that this is being tackled right now. So just to put this in perspective, I'm going to cite some numbers that probably a lot of the people here know. Aid is about 1% of the US budget. I guarantee a lot more people know that now than used to, because there are lots of studies that show that people think foreign aid makes up something like 20% of the US budget. It's about 1% of the US budget. USAID is the largest part of that, but by no means the only part. USAID's budget annually is about $40 billion. The foreign aid budget, to put it in perspective, is about 7% of the budget that we spend on defense in the United States. It is also the USAID budget, an interesting fact, is about 10% of Elon Musk's net worth. Aid, as we know it, goes back to World War II and the creation of the Marshall Plan following World War II. This was done by an act of Congress. And it was seen as an extraordinarily successful carrying out of US foreign interests through foreign aid policy. This is one of the huge mischaracterizations that has in the news right now, is that somehow foreign aid is charity, somehow it doesn't serve the US national interest. Every law enshrining US foreign aid into US policy has discussed how it serves the national interest of the United States of America. Every law. This is not something new. This has always been acknowledged. When Kennedy came in, President Kennedy came into office in 1961, he went to Congress and he said, I don't like the way foreign aid is run right now. He basically said it was terrible. We need to reform it. And he worked with Congress to reform it. And out of that reform came the Foreign Assistance Act of 1961, which is what created USAID. More specifically, Congress authorized or mandated the president to create a body that became USAID. So shutting down, and this has been reaffirmed in multiple laws since then, shutting down USAID without going through the US Congress is unlawful. It's also very inefficient. Secretary Rubio has said, just in the last couple of days, I think when he was in Panama, that of course some of the programs that USAID does are good, and of course they should, his words, should continue. But a very inefficient way to continue the programs that you want to continue is to shut them down for 90 days first. You can't just reach the way foreign aid works. There are thousands of different local implementing partners on the ground. They can't sit around for 90 days waiting for the money to be turned back on. They won't be there anymore. They'll have moved on to something else. The staff that are being recalled won't be there anymore. The lucky ones will have moved on to other jobs. They won't even be there to be called back. So this is going to be extremely inefficient. It's also, from a programmatic, one of the things that I study is smallholder farmers in Central America. If you don't plant the seeds at the right time, or you don't apply the fertilizer at the right time, you can't just do it 90 days later. That's not how farming works. I grew up on a farm. If anybody, in the government wants to talk about that, I'm happy to. This is going to have a huge impact on food insecurity, which is obviously also a health issue. It's also, in Central America, one of the largest drivers of migration to the US southern border is food insecurity from rural areas in Guatemala and Honduras. One of the top drivers. So it's completely counterproductive to other goals that the US says that it wants to do. And finally, this is going to make the US weaker. I was listening to reports just before coming in here where health agencies in countries that have been relying on the United States are calling up China and Russia to see what they can do for them. US foreign aid was always seen to be a measure of US soft power abroad. It's been recognized as that from Democrats and Republicans since World War II. Dismantling it like this is not efficient. It's not going to save money. It's going to cost a lot of money. And it is going to make the US weaker. And I'll leave it there.
This is why we need a political scientist to talk to us about global health. Thank you so much, Sarah. And Gavin, your center has done a lot of work over many years now, also assessing the impact of changes or pauses or actual stoppages in foreign assistance and measured those impacts. And I think you really led important epidemiology on. So maybe you could share with us some of those experiences. What do we know has happened when one of these interruptions occurs?
So thanks, Chris. Thanks for the opportunity to be on this very distinguished panel. And as Gerard said, thanks for your moral leadership during this very unprecedented time. I wish it was precedented, but here we are. And thanks to Gerard, Dorothy, and Sarah for their powerful insights. And that's right, Chris. Our centre, working in partnership with universities and think tanks in 6 lower middle income countries, Ghana, Kenya, Nigeria, India, Sri Lanka, and Myanmar. We have been studying what's called transition or graduation actually since 2016. Those 6 countries, by the way, are all on their transition journey, transitioning out of aid towards domestic financing of health. And transition, of course, is at the very heart of decolonizing global health, right? We all want countries, every country in the world, to be able to finance and lead and own national health programs without dependence on foreign aid. So when you see a successful transition, that is a good news story in global health, right? It means that a country has a strong enough health system delivery system, and it has an economy that can resource mobilize. It can mobilize domestic resources. It's got strong public financial management. And donors, of course, have committed to this. Donors have committed to supporting countries transitioning out of aid. Take a look at PEPFAR's most recent strategy. Gerard will know it very well. It has a sustainability pillar. And in that pillar, PEPFAR commits to helping countries mobilize domestic financing and gradually increase country ownership over national HIV control programs. But the key word is gradually. And our research that we've done over the last decade or so shows that transition has to be done in a way that is careful, safe, planned, unhurried. And sudden, chaotic withdrawal of external funding from donors causes resurgence, particularly, I'm going to come back to this in a minute, particularly amongst the most vulnerable groups. A successful transition, it typically takes a decade or more. And during that time, the transitioning country is strengthening its health system, strengthening its public financial management system, and typically it is spending a little bit more, a little bit more, a little bit more, year on year on year on year, so that when the donor finally leaves, it's not facing this catastrophic withdrawal of funding. It's not a massive spending cliff. And there's actually a whole series of transition readiness tools, transition planning tools. We've done research assessing the benefits of those tools. And the donor and the country working in partnership are using those tools to assess things like the epidemiological situation, the country's finances, the human rights situation, the gender situation. That's really important. And the idea is to use these tools to identify gaps that can be filled before the donor leaves. Crucially, you have to have a plan in place to reach vulnerable groups, key populations, with HIV prevention and treatment services before the donor leaves. And often in successful transitions, this has been done through so-called social contracting, where the government contracts with CSOs or NGOs to ensure seamless continuing provision of prevention and treatment services. So let's be just incredibly clear about this. Freezing US health aid overnight is the exact opposite of a well-managed, careful transition. And there's a study that we published where we examined donor transitions out of HIV services that I think is quite instructive, because we gave examples of where donors left suddenly. I mean, you can see what happens if support is withdrawn precipitously. So in 2010, for example, during the first wave of donor transitions for the Global Fund started to leave countries. Romania was a first wave transition country. And the Global Fund left suddenly, and there was no plan in place for the Romanian government to fill in the gap, particularly for prevention services and particularly for vulnerable populations. And so when the Global Fund left, prevention services collapsed for people who inject drugs, for men who have sex with men, for sex workers, and among people who inject drugs, the HIV prevalence rose from about 1% in 2009, the year before the Global Fund exited, to 53% 4 years later. 53%, that is an absolute catastrophe, a human-made catastrophe. You can also look to see what happens with malaria. I have a slide up. We did a systematic review to see what happens when you halt malaria control programs, where there is still ongoing malaria transmission. Our systematic review, we looked back through history to identify every example we could find of malaria resurgence. We found 75 resurgence events in 61 countries occurring from the 30s through the 2000s. And in almost all cases, and here you can see Asia and Eastern Europe, about 68 out of 75 of those resurgence events were due, at least in part, to weakening of the malaria control program, usually because funding was disrupted. I was always told that a good figure, a powerful figure, a person at the back of the room to be able to see it and get the story, right? You see something stopping, the malaria control stops, and bam, the malaria parasite prevalence rises quickly afterwards. So we should be concerned as scientists, as public health folks, as global health folks, to know that as a direct result of the US freeze, for example, you will have seen Uganda's National Malaria Control Program announce it has had to suspend spraying insecticide into village homes, and it has had to stop distributing bed nets to children and pregnant women. The result will inevitably, because there's ongoing malaria transmission, be malaria resurgence, sickness, and deaths, especially in kids and pregnancy. So the message from our research, Chris, is quite clear that Trump's very sudden disruption to funding disease control programs for HIV, malaria, TB, Marburg, Mpox, childhood diarrhea, and on, is going to wreak havoc. And this idea of freezing overnight aid, that is not about accelerating transition. It's about blowing it up and causing human-made disease resurgence, which is an absolute moral catastrophe and disgrace.
See, did I not tell you? Thank you so much, Gabby. That is really powerful. That's the end of the formal questions. We have about 20 minutes for questions from the audience, and we have a number of questions online in the Q&A. But maybe we'll start with the folks in the room first. Please.
First, thank you.
And also, if it's to a specific number, just let us know.
Oh, I think maybe to the whole room.
Okay.
I think these are hard questions. First, thank you for speaking on something that's actively ongoing. That's really hard to do. And second, I just want to acknowledge before I ask any questions that I think that every single person, or at least the vast majority of people in this room, are directly affected by the things that are happening, and that's like painful. And so like I feel grateful to be in a space where people can be in pain together. And thank you for coming to do that. I think something that I've found really frustrating and difficult about the last few weeks as a global health student, as someone who's interested in a career in global health epidemiology research, is I think everyone here can accept the facts of how challenging this is and how devastating and how much suffering and like frankly death will happen as a result of some of things that have already occurred. But it seems really unclear to me what direction statements, which makes it really difficult as a student, as an early researcher, perhaps even as a senior researcher, to move beyond the like grief and shock phase and into the, do we organize? Do we leave the field? Do we like where do we move? And I don't think that's like a question that has a specific answer, but I would love to hear what other folks are thinking about it.
Well, I think it's on all of our minds, and it's obviously a very big question. I don't know if any of the panelists want to ponder that or take it on. I will tell you that I think it does relate to a question in the Q&A, which is also about if what is happening is unconstitutional, how can it be redressed, and what are the legal options? And maybe Sarah, you could speak to that.
Yeah, so now I wish you'd asked a constitutional law scholar to be on the panel. But when we put this panel together last week, we didn't quite know where it was, where
Yeah,
events
yeah.
were going.
Minute.
It is minute by minute. Look, it is not my place as a Duke professor to tell people ever what they should do. It's my place as an expert to point out, realities on the ground and call things the way that I see them. I will say, there are, from my understanding, and this is not my expertise, there are multiple ways legally this could play out. One is through the courts and one is through Congress taking action to reverse this. Both of those are hard paths. And both of them, the Congress one could happen relatively quickly, the court one takes time. So those are kind of the two levers that could be pulled to, or of course, the executive branch could change its mind. I mean, that's the third. We have 3 branches of government. And if something's unconstitutional, one of them has to stand up and do something about that. So those are the pressure points. Those are the avenues to voice opinions of whatever those opinions might be. But the court one is a long slog. But there are people out there making statements, both from academic communities, from NGOs. I will say in my conversations with NGOs this last week, and I'm sure this is across the board, they are in a very difficult position because they want to save the lives on the ground, and if they speak out, they may jeopardize their ability to do that. And that's one of the reasons that I think fact gathering and putting the facts out there so that people have them, talking with people just about the facts, that's what I do. That would be one of the things that I would recommend. If you have.
Yeah, maybe I could just echo that. I think that, the question that has arisen is what is the role of the academy and the university in all this? And I think that's exactly right. We are seen as independent, we have academic integrity, we can put our facts. And as Chris alluded to right at the beginning, it's not about the politics, it's not about being partisan, it's about saying, look, here are the facts, this is what is happening. With the tools that we have as scholars, we can also, for example, model the likely impacts, as the AMFAR paper did, and that's been very influential. And I think continuing to state the facts and to research what is happening and to explain that to the public, and potentially also to, folks on the Hill. And we are all accustomed now to framing those messages in ways that we hope will resonate with different kinds of policymakers, right? Once briefed Tom Tillis' staff, for example, and you have to frame it in a different way, usually through the economy and the brilliant returns to the American economy and, security and foreign policy benefits. And I think we're going to have to think about how we frame those messages to those kinds of audiences. Then there's a broader geopolitical question about, are there other donors who could potentially step up? I mean, I have to say, we are by far the largest provider of foreign assistance. And the idea that suddenly other donors are going to, fill in the $70 billion of annual aid from the US is kind of preposterous. But there are gaps that they could fill. Donors have filled similar gaps in the past, not similar in size, but when the US has retreated from reproductive health, Scandinavians have picked up pieces, for example. So you could hope to see some of that as well.
Yeah, I think that's right. And maybe just one other reflection, which is that it often seems like, what can we do there? How do we respond? The fact is that the life-saving waivers were the result of intense activity. And we got them. And they have come forward. They're not They're insufficient, but it's not like was no response there. There was very much a response. I saw another hand.
And Gerard wanted to say something.
Oh, yeah. And then,
Chris, thanks, Kevin. Chris, just on this, what do we do in this moment? Students who are looking for careers in global health. I just wanted to also reflect your point about the waiver, and the reason why we got the limited waiver was because of the advocacy. I think it's important to also to stay in constituency because there isn't a large constituency for foreign aid for global health, right? And I don't think it's a coincidence that the only other thing that happened on day one that was related to global health, and it happened before this, was the U.S. withdrawal from the WHO. And the reason why, well, and the climate one as well, but because global health is not an election issue, it's not a issue that's top of mind for voters who are, struggling with so many other day-to-day issues. It's so easy to slash and burn and cut these programs for people who don't understand the ramifications of it. And that's why it's so important for there to continue to be a pipeline of students, of professionals, to be in this work, to analyze, as Gavin was saying, to put out the information there, to stand up, to go to the protest, to talk about what's happening. I was really inspired 48 hours ago with a huge protest. There must have been at least 1,000 people outside the USAID building, including members of Congress. 3 or 4 senators were there, 10 House representatives were there. There's another one this afternoon. There's another one tomorrow on HIV. We are the face and the constituency of global health in Washington, and we're only strengthened by more students, a younger generation of people entering this work, and it's just so important. So if you're even thinking about changing your career path, don't. That's my advice.
please.
Yeah, thank you all so much for this incredibly important panel and also gathering. I agree. Catherine Turner with Global Citizen and also adjunct professor at UNC Gillings. So I appreciate the points that you all are making that are so important for us to advocate with others about the U.S., North Carolina interests in U.S. foreign aid and USAID. North Carolina is, I believe, the 3rd largest recipient of USAID dollars, and that's an important message for our legislators. And also thinking about the organizations, the companies that are all being funded by USAID, and also that what happens in other countries directly affects us here in North Carolina, in the US, in terms of preventing global pandemics. All sorts of these health issues are not only happening in Tanzania, although that's reason enough from a humanitarian standpoint, but they also affect us deeply here in the US and in North Carolina more specifically. I also think, in addition to educating people about the millions of people's lives that are being affected and the economic impact, we also have to look at the reasons why Elon Musk and others who are not elected officials are dismantling these organizations and the economic and business interests that they have. Why are they accessing classified information that gives them access to these global data that directly serve their business interests and their business interests with China, for example, that we're creating a gap for China and Russia that's directly serving the business interests of these oligarchs that are in power. So I think the health arguments are important. And we also, like Senator Chris Murphy in the press conference was very carefully elaborating on the business interests that are being served here and how it works against the US people. These are US people's dollars. We paid for these programs. So there's the unconstitutionality of it. And there's also that these programs belong to us. We paid for them. We pay for them in the present tense. And also really in terms of gathering with others, agree very much with your point about we need to, united, we're stronger. So just making sure that people, Duke is a member of the North Carolina Global Health Alliance, having a members meeting on Monday at 1. Encourage you all to participate in that, to join in force with other global health professionals. And then if you aren't already a member of Defend Public Health, is a group of global and public health professionals and professors who are 2,000 and growing to work together to defend these issues. And I can share information, but it's defendingpublichealth@gmail.com. You can join committees that are working. I'm calling my senators daily. I hope you all are too, but feeling discouraged about Senator Tom Tillis's quote in the paper, quote, "It's time to put someone in there," meaning RFK Jr., head of Health and Human Services, who's going to go wild. He happens to be a disruptor, and he wants to bring in new ideas. So this is the kind of mentality, which is unfortunate because I've met with Senator Tillis's team a number of times, and he's traditionally been a supporter of at least U.S. foreign aid. But these views on RFK Jr. as head of Health and Human Services are really problematic.
Well, thanks for that. I just want to say I have been going through the questions for the online audience, and there's almost 400 people attending online. But many of the questions, the themes in the questions we have been addressing. So I hope we've been able to address some of your concerns. We've talked already about the legal issues, the constitutionality, and some other aspects. Please.
Hello, Justin from across the street at the School of Nursing. So thank you for hosting us today. My question is kind of, Dr. Gabby Yami, sorry. You mentioned gaps and future opportunities. I am curious if maybe there is more research or you have insights into what it looks like when private institutions, foundations step into those gaps. I'm kind of, the first thing that comes to mind is the Bloomberg Foundation funding the Paris Accords, but I know there are economic incentives for climate change, but maybe not other health factors. Will there be some that are left behind? Colonial aspects. I'm just curious if there's research.
I mean, it's an unknown, and I love your views on this as well. In fact, we did a study together some years back on how donors behave in concert. We actually particularly looked at when Gavi, the Vaccine Alliance, the main multilateral funder of vaccines, when it enters a country, do you see other donors enter? And when Gavi leaves, do other donors leave? And there does tend to be this herding. It's a huge question. Are other foundations, are other philanthropies, are other donors going to step up? And I don't know. I mean, it's early days. As I said, the volumes are enormous. The NIH is by far the largest public funder of biomedical research in the world. It sounds very likely, particularly if you look at who Trump wants to lead the NIH, that their next phase is going to be about ending, quote, woke science. I mean, that's their now explicit stated mission. So I think it's highly likely that you will see cuts in funding. I presume they, define woke science as inequities in health, health disparities, structural racism in health, LGBT health, climate health. I do think those areas are going to get defunded, sadly. And I would love to see other funders stepping up and proudly saying, no, this is the core of health research and public health research. And, our profession here of global health has equity at its core. The notion that you could strip out equity from global health is utterly preposterous.
It's our mission statement, but okay.
I was heartened yesterday. You may have seen that 2 journals came out very publicly and said this is absolute nonsense. We are going to continue to publish these studies. The BMJ, the American Journal of Public Health. There has been an attempt now. If you're a CDC researcher, you've been told that if any of your papers under submission have got the word gender, for example, and other words, you either have to come off as an author or retract the paper. That's deeply unethical. I mean, that's publication misconduct, and the BMJ has said that. So I'm pleased to see journals stepping up. I would like to see scientific institutions, scientific bodies, universities stepping up to say, we're not going to go along with this.
Censorship.
Of course, it's censorship.
Yeah.
Kind of as a follow-up to that, and as well, what we were hearing from Gerard, just, now's the time to be active and kind of loud with what are the things we can do to, educate other people about what's going on. And for those of us who aren't career, global health researchers, maybe within DGHI, within larger Duke, or just with any other resources, I guess nationally, has there been talk around like communication strategies for creating materials to share information about these consequences?
Well, yes, and let me just add, you're stealing my thunder in a little bit of a way, but with students in particular in the room, one of the things that has emerged is the idea that it's going to be really important to document and understand and collect the data on the impacts of these changes and what is happening, and particularly prospectively to do that. So I think a number of universities, I've been on several conversations with other folks at Yale, at Columbia, where the idea is sort of emerging early on that we need to be doing this in a concerted, proactive way, and we're going to ask for students to get involved if they'd like to do that, to help with that work. So I think that that's going to be really important. We, we all have lived, and I'll tell you, over the arc of many years, that there's nothing like evidence to change a conversation. Even in an environment where it feels like people are not paying attention to the evidence. The fact is that, you can, for example, document an increase in perinatal transmission of HIV. Now, we're really going to have a whole new cadre, a whole new cohort of infants and children living. That is something that does move people. And it's not just quantitative data, which we also will need, it's also qualitative data. And so that's, I think, going to be a very important part. We've had some big wins in the past by getting important voices to the table. I was reflecting from the early days of HIV, the Ryan White Care Act, which funds so many programs in the US, it has for years, did not have enough votes to pass until Ryan White's mother was brought into the Congress and talked about losing her son to HIV, and she got it over the finish line. So qualitative human aspects of this also really matter. Sometimes they're more moving to the Congress and to other decision makers than our odds ratios and confidence intervals. You can't imagine why that would be the case, but it is. And so, yes, I think that hopefully that's going to be something. I'm afraid we're out of time. Let me just say, first of all, I want to thank everybody for participating and for the online audience. I think these panelists have shed light on the challenges that we're facing on the political, historical context, on the epidemiology, on keeping us current on current events, which are so hard to do, and Dorothy speaking for what you're seeing on the ground. So please just join me in thanking these extraordinary